Okay, so it's 3 o'clock, so I suggest we get going. Welcome everybody, and thank you for joining us on this webinar today. This webinar is about the IMI ConcePTION project, and we'll discuss a little bit what IMI is and the organisation of the project a few slides down the line. But we're going to start off by talking about the reason behind this 5-year plus project. But first of all, I'm Michael Steele. I work in the Chief Medical Office at Novartis in Switzerland. And I co-lead this project with my partner in crime, Miriam Sturkenboom. Miriam, would you like to introduce yourself?
Yes, thank you very much, Michael. So my name is Miriam Sturkenboom. I'm a professor at the University Medical Center Utrecht in Health Data Science. So thank you for joining, and we love to tell you about ConcePTION. Thank you.
Great. If we go to the next slide, Miriam, or Miriam, I'm not sure who's presenting. Just before we kick off, if you have any questions at all, please pop them in the chat box, and we'll be looking at that. And we'll deal with all the questions at the end, well, all of those that we can, and any we can't, we will get the right experts to get back to you. So, as I mentioned, this is a 5-year plus project, really looking at the effect of medicines on breastfeeding and on pregnant women and the outcomes for their babies. So, why did we do this? Well, we believe certainly that every woman has the right to safe and effective use of medication based on good evidence. And is there good evidence? Well, globally, the impact, there's 200 million women get pregnant each year, of which 5 million are in the EU. On average, women take about 1.6 medications through their pregnancy. So it's, of course, most women wish to avoid medications during pregnancy, but you can't always. Some women have chronic illnesses such as epilepsy, such as multiple sclerosis, where they could get seriously ill if they cease their medication. And of course, women have acute illnesses as well, such as infections. Proper evidence about medicine safety is really very lacking. And then if you look at the evidence, and we'll come back to this in a minute, is very inconsistent. So there's a huge burden of uncertainty, both with the women and the healthcare professionals who are treating them. Lovely. So why is there a knowledge gap? Well, of course, preclinical work is done, but some of the animal studies may not be predictive of what's going to happen to the women and baby with the drug exposure. But generally, research in phases 1 to 3 of pharmaceutical research, pregnant women are usually excluded, unless, of course, it's something specific for pregnant women, such as investigating drugs for preeclampsia or something like that. So most of the evidence we get is in the post-approval stage, when the drug is out there, it's on the market, but women, as I mentioned, do have to take these medications. And then it's our job to try and gain as much knowledge about what happens when a woman gets exposed during pregnancy or breastfeeding to these medications. If we go to the next slide. So what is the situation at the moment? Well, from the FDA labels, 91% of drugs are classified as having an undetermined teratogenic risk. And certainly from the EMA review of centralized licensed medicines, 71% had no information, 83% had no information of use during lactation, so even higher. And only 3.7% allows the use in pregnant women. If we go to the next slide. So, when my background, I was a physician for many years before I joined the pharmaceutical industry in my midlife crisis. And in those days, we didn't really have the internet because I'm very old. So what did we do? Well, I'm British and I used to consult the British National Formulary. one would be reading publications, etc. But it was hard. You didn't have hardly any options, but the options at least were consistent. Now everyone goes online. So one of the first things we did in the conception project is look to see what happens when you go online. If we go to the next slide, please, Josephine. Lovely. Unfortunately, and this is published, the reference is down at the bottom. You can certainly look at that after the webinar. We did an extensive look in 4 different European languages, what you found when you started searching on different drugs. And the results were quite shocking, really. In pregnancy, 54% of the recommendations were inconsistent between the different data sources. And for lactation, it was 83%. None of the medicines we looked at had a unanimous, consistent pregnancy and lactation recommendation. And some of the recommendations could be totally divergent, varying from, oh, it's fine and safe to take the drug, versus it's high risk to the baby by taking this drug. So clearly, we need much better information available for these women and their healthcare professionals. And we need that information to be evidence-based and consistent. So if we go to the next slide. So our mission in Conception is to build a trustworthy pan-European ecosystem, and Miriam's going to describe that ecosystem in a little while, for not only providing good information, but also for generating that evidence-based information, monitoring it, and being robust. If we go to the next slide. So what is the Conception Project? It's the IMI ConcePTION Project, which stands for the Innovative Medicines Initiative. The Innovative Medicines Initiative run many projects which tend to be long-term. It actually changed its name to IHI, which is Innovative Health Initiative last year, but we're still under the IMI banner. It is funded by the European Union, and it is co-led by Novartis and UMCU, as I described earlier. Industry contributes significantly. We don't usually provide funds, but we provide significant resource in terms of people and in terms of data. The original duration of the project was from April 1st, 2019 to the end of March next year, although we are requesting a slight extension to the end of next year. Obviously, things like the pandemic affected everything, especially in healthcare. There are actually more than 200 people working on this project from 88 organizations, including the European Medicines Agency, pharmaceutical companies, academia, small, medium enterprises, public health organizations, women's health organizations, and very importantly, members of our European Teratology Network associates. We go to the next slide. Geographically, we're spread right throughout Europe, and even has some representation from South Africa. And also, I'm not sure if it's showing on here, we have Israel involved in this initiative as well. If we go to the next slide. What has happened during conception is to pull together a lot of different sources of information that were working independently, quite correctly. But if we're going to work on providing better information, what's important is moving forward, we can link that information together and work together in a more coordinated manner. We go to the next slide. So the 3 main areas of questions the project was raising were, obviously, as I've mentioned, are medicines harmful in pregnancy? And so what we need to do is to, as I've mentioned, look at the electronic health data that's out there and try and pull that together so we can get more robust evidence, but also rethink think the way moving forward we collect prospective data from reported cases of exposure during pregnancy. In case I forget anywhere during this, this webinar, the important thing is the exposure, not just collecting any abnormalities that have happened during the pregnancy. Because we also need to know, just as importantly, which drugs are safe when drugs are taken and no abnormalities are found. That's just as important as finding when abnormalities are found. Secondly, do medicines transfer into breast milk? Obviously using data from cells and animal models, and also how to collect data in humans, how to store, ship, and do have the whole process in a validated way. So those two first parts are really about data generation. And then the third part is much more about data dissemination. So once we've got that data, then how do we create and maintain a really trustworthy European-wide knowledge bank, which can be used by both women and healthcare professionals? How we harmonize the knowledge synthesis, and what that means is, so from all the different literature searches and identification of the different sources for the information, how in the same way do we consistently analyze that information? And finally, in that work stream, we are also producing a healthcare professional teratology training program, so that when healthcare professionals are actually looking at the data that's coming out of the knowledge bank, they will be able to go into the references and understand what they mean. So if we go to the next slide, please. So how do we create a conception ecosystem? And at this point, if hopefully Miriam is back online. Is Miriam there? Ah, you are. Good. I'm going to hand over to you.
Thank you, Michael. So how do we create the conception ecosystem? Next slide, please. Here you see the pieces in the green box of the design of the ecosystem, and that needed to be established. So it starts on the left hand with all types of different data that we would like to utilize to both study pregnancy as well as lactation. And we'll talk about those data sources. We also need to know where the data is, so to create a data catalog. And FAIR stands for findable, accessible, interoperable, and reusable. So we want the data to be in a FAIR data catalog. Then data access needs to be arranged, data harmonization, quality management and verification. And then you see signal detection and rapid assessment and evaluation. So this concerns the conduct of studies that generate new evidence. Now, all the evidence then that is created both in the conception ecosystem, as well as information from publications or outside, need to be put together, reviewed, and actually put in the knowledge bank on the medicine level. So that's how the ecosystem fits together. So it starts from data and goes all the way through these various steps and components into evidence that can be utilized by women and healthcare professionals. Next slide, please. So I would like to go through some of the achievements and what conception has done. So we will start out with the achievements in the area of pregnancy. So we, as Michael just explained, we have the areas of lactation and pregnancy. So I'll start with pregnancy. So the key question to be addressed in pregnancy through the conception ecosystem is which medicines are used, and do these medicines actually do harm to mother or baby when they are used in pregnancy? And we know very little about that. So in conception, we know that even if we do not have the evidence on the effects of medicines in pregnancy, pregnant women with illnesses are treated every day. So about 90% of women during their pregnancy use one or more drugs or medicines. So it is a very frequent issue. Now, in the absence of evidence from clinical trials, we feel that conception has the moral duty to actually study the data that is generated or can be collected from real-world healthcare systems after the medicine is licensed. So during the routine healthcare that is happening every day, data is generated. And so we feel we need to study that to actually learn from it. Now, in order to do that, a couple of hurdles needed to be solved, and we see 5 here. So I'm going to go through each of them. So hurdle number 1 is, if all of this data is generated during the healthcare process, where is it actually? And the second hurdle is, can we actually use that data or potentially collect new data if that is needed? The third hurdle to be addressed is, how can we actually analyze heterogeneous data in the electronic healthcare record that is actually fragmented? It's stored in different locations. And what we would like to do is to analyze it in a similar manner. So to not have heterogeneity in analysis, but to homogenize and harmonize that. The fourth hurdle that needs to be addressed in the conception ecosystem is to know whether the data that we are using is actually of good enough quality to have robust evidence. And we'll talk about the quality checks that we have created. Then the fifth hurdle is really the question whether we can create a rapid and robust pipeline to analyze the real world data, so all these various types of data, in a transparent manner to generate that real world evidence. So what we aim to create is the ability to rapidly learn and it to be robust. Next slide, please. So in the pregnancy research, what type of data do we reuse? First of all, that is both animal data, and we don't generate new data from animals. We actually use what is available from preclinical reproductive toxicology data that is collected and information that has been submitted for licensure and is publicly available. So during the preclinical process, tests are being done and that evidence is being utilized and then linked to the clinical data. So the human data that we are reusing in conception is 2 types. And first of all, it's pharmacovigilance or surveillance data. So those are reported exposed pregnancies or active data collection from women. So it's about a woman having using a specific medicine during pregnancy, and we collect information either available or de novo from those women. The second type of human data that we utilize is actually routine healthcare data, and often this is population-based. So on a population that can be enumerated, we know what events occur, what medicines are being utilized, and we use that data to generate the evidence that we need for the studies. So we call that electronic healthcare data sources. And also we use national pregnancy registers that can be linked to those electronic healthcare databases. Of course, when we use this data, it's pseudonymized. So we do not know the names of the subjects, but we can use it in this manner to learn. So now I would like to go through the answers to the various hurdles, the 5 hurdles that I mentioned that we needed to overcome in building the ecosystem. So the first issue was, if all of that data is available, where is it? And a catalog was created, which can be searched online, that actually describes both institutions that have access to data, the data sources that they can access, the data banks in those data sources. So it can be different data banks such as hospital data, GP data, pregnancy registers. Then the common data models that have been utilized to transform that data into the studies in which these organizations participate and where the data sources are being utilized, also networks in which they participate, and then contact information. This catalog has been populated with information on more than 400 data sources. Next slide. So then if we look at the answer to the second hurdle that we had, that was, can we use the data that is available for the conception ecosystem? We have looked at two different data providers. The first were the women. So if we, for example, think about the case report or including women de novo in data collection, we have conducted an interview with a qualitative interview with 20 women during preconception, pregnancy, or nursing, and had topics that were discussed and then analyzed. The results of this show that women are positive about a learning health system for pregnant and breastfeeding women to help diminish the knowledge gap. Second, women want to contribute to the development of new information and engage in such a learning health system. Women view their healthcare professionals essential, especially in the translation and interpretation of information. So they don't want to receive all of the information crudely, but they want it to be received through the interpretation of their healthcare professional. The fourth result was that women see trust and transparency as essential for the realization and sustainability of a learning health system. So especially organizations that would be generating the evidence would need to be trusted and of high quality. Next slide. So these were the women. We also conducted interviews with data access providers, so institutions that can access information from electronic health record data on large populations. So they have this information in-house or can access it. And 14 of such data access providers, as we call them, so these are institutions or representatives of institutions who are participating in the conception project, were interviewed. Also here, qualitative interview with a certain topic list. And the results there show that the respondents typically view the collaboration as an opportunity, so the collaboration in a learning health system, for many reasons. They would like to contribute to this. They have different interpretations of responsibility. So they have only specific roles in this whole ecosystem, and they may have different wishes there. It's really important for the institution, for the data access providers, that resources are available, that there is important scientific output and agreement regarding the participation of pharmaceutical industries, and also transparency are important conditions for participating and committing to the conception learning health system. Next slide, please. So then the answer to hurdle 3, and we saw from hurdle 2 that people want to participate, both women and health and data access providers. So then the answer to the hurdle 3 is, how do we use the heterogeneous electronic health record data in different locations? So we have established a set of principles. First of all, data stay local. So we don't ask people to ship data to a central site, or we do not create a data lake. Data stay where they are in the institution that can access them. Second principle is all sites, if they work on a certain study, use a common protocol. So we all use the same definitions and outcomes, etc. The third principle is that sites use a common data model. So you can see in the graphic below that each of the sites may have data in a different shape or format. So that's on the left-hand side. You can see above original data, all different shapes and colors. It means that their local data, they may have different table names or variable names. And what we do within conception, or what we require, is that people extract data from their original data and transform and load that into a common, what we call a common data model. So this is what we call the syntactic harmonization. It gets into the same structure so that the variable names and the table names are the same. When this happens, what we can actually do is we can send the sites an analytical script that will then transform that data from that structure into evidence. So we all use the same analytical script, which makes it efficient and also more transparent what is done locally. These scripts that we utilize to generate the evidence, which then the results only will be shared on a research environment, the scripts are open source when they are finished. So we commit to open science. Next slide. Here is a slide which may look very complicated. It's a bit of a deeper dive into the common data model. So as part of the conception ecosystem and project, we have defined the conception common data model for EHR data, for the electronic health record data. And what you can see here on the right-hand side, these are the different tables. So it's person, observation period, you see the whole list. And then there is a set of metadata. We have learned that the ETL, so the extraction, transformation, and loading of the original data to this conception common data model can actually be done quite rapidly or in a limited amount of time by the data access provider. So the ability to participate in studies for conception is actually doesn't require a lot of upfront investment. We have plotted the OMOP common data model. This is another common data model that is widely used also in other IMI projects, and we show the difference here. And the difference is not in the type of tables that are being utilized, because they are actually almost the same. The left-hand side of the OMOP common data model is similar to the conception common data model. But in the OMOP common data model, data access providers are requested not to only transform it into the same structure, but also do a semantic mapping. So making sure that all type of common vocabularies are being utilized. And experience has shown that that requires a lot of investment in terms of time. So DAPs often are required between 6 to 12 months to transform their data. So this is the choice in conception, and it has been working well to work with this common data model. So the conception one. Next slide, please. So this was the common data model that I just described for the electronic health record data. So also for the case reports, a common data model has been defined, and you can see here again the same principles. There is multiple types of data, whether this is intensive monitoring or pregnancy registers or teratology information system data sources. The data stay local, they are in the organizations. We asked the sites that participate into the studies to harmonize their data to core data elements. Then they are common data model compatible, and then you can send the analysis scripts that create the results that then are loaded onto the data platform. So very similar approach to what was done for the electronic health record data. Next slide, please. So the hurdle number 4 is a critical one. It's whether the data that we actually use and that is not collected for research, but actually for another purpose, namely healthcare, whether that data is good enough to generate the evidence that we need. So can we rely on the evidence that is being generated? So a lot of regulatory agencies now are very busy with defining quality criteria for real-world data. And what Conception has conducted is to build a pipeline to check actually the quality of real-world data. And we call that the data quality check pipeline. So what it is, it's actually a series of scripts in R that can be launched against the data that has been converted to the common data model. And it creates 588 different metrics or calculations that allow us to check whether the data instance that is created is actually fit for purpose for the study that we need. So we have various level checks. The first one looks first whether people were coherent and complete in transforming their data into the common data model. Level 1B creates a count of all type of variables, and it gives distributions and allows us to check semantic coherence. Level 2 is actually looking at plausibility of the data. So for example, do we have visits for a person before they are born or after they die? All type of checks that are logical for the data. The third level is really about the content. So is the data do we capture the medicines? Do we have the events that we want? And does it make sense? Like, is it consistent? Can we benchmark it against existing knowledge that we have so that we know that it's reliable data? Now, this quality pipeline has been used for more than 10 different regulatory required studies by the EMA on both vaccines and medicines, also outside of conception, across a wide series of data access providers. So it's working. Next slide. And so that's a great achievement, I think, of the conception project. So then the fifth hurdle was the question whether we can actually create rapid and robust evidence. So does the pipeline work? So that entire box with all the pieces that we had created to design, does it work? Currently, within the conception project, we are conducting 5 different demonstration projects, as they are called. Each of them has multiple studies within them, ranging from drug utilization to safety assessment, creation of algorithms, etc. And they go by a specific type of medicine or a therapeutic area, but also looking at methodology. So there is a demonstration project on neuropathic pain, looking also at compounding by indication mostly. And then there is a second project, which is looking at antidepressants and mental health disorders. A third project that is focusing on multiple sclerosis. A fourth one that is looking at migraine and medication for migraine and intermittent medication exposure. And then there is a fifth demonstration project that is looking specifically at breast cancer during pregnancy and the drug utilization and safety around that. Now, these are the studies that are ongoing as part of the conception project, which we aim to finalize by the end of the project, of course. But importantly is that the pipeline has already been utilized by more than 10 regulatory requested studies. So there are other consortia and associations that have embraced the conception pipeline and the concepts and are using it already to generate evidence that is required for the European Medicines Agency. Next slide. The demonstration project is part of the case reports. So it's really like the exposed pregnancies are also ongoing as part of the conception project. And here you see 5 different demonstration studies that are ongoing. So focusing on pregnancy pharmacovigilance, collecting data prospectively, long-term outcomes in the lifetime project, so in neonates, and then some specific projects that are ongoing that you can read here. Next slide. So at this point, I would like to transfer again to my colleague, Michael Steele, who will talk about the lactation research.
Thank you very much, Miriam. So moving swiftly on to lactation research and do the medicines transfer into the breast milk. If we go to the next slide, please. So fundamentally, there's several parts to this. The first part is obviously to try and get more predictive models by really choosing the most optimal animal based on physiology, logistics, etc. And I'll briefly describe a study on using the moxicillin on the mini pig model, which has been deemed to be the most appropriate. Secondly, it's really then starting to understand what happens in humans using cell cultures, etc., looking at drug transport systems, then using mathematical modeling to really try again having physiologically based PK models. And the other part, the last part on here, which is a huge piece of work, is really once we get into studying this in humans, how do we collect? How do we ship? How do we store? And then how do we analyze human breast milk in a consistent and validated manner? That's not necessarily easy. Okay, so if we go to the next slide. Thank you. So I mentioned we were just going to mention the in vivo study for amoxicillin based on the mini pig model when there was blood analysed both from the mother and from the piglets, and then also obviously to see what was in the milk. And the conclusions are down here on the right, and the amoxicillin plasma concentration peaked in the mother after about 2 hours. It was present in the milk in similar manner, but there was no amoxicillin found in the piglet blood. So it was getting into the milk, but then it was not absorbed into the mini pigs. And there were additional endpoints, etc., taken in this study. So it was really good to show this model worked. If we go on to the next slide. Next is what I mentioned about the human lactation studies. There's a tremendous amount of work being done using different centers across Europe. And the first model, or first demonstration project that was run in Norway to really see the feasibility of being able to, in a standardized way, collect the milk, ensure it's shipped in a proper manner, stored in a proper manner, and then analyzed. If we go to the next slide, please. And so in that regard, in terms of the human models, basically we set up the infrastructure, the technical human capacity to conduct the in vitro animal in vivo studies, PK modeling, and the human lactation studies. And right now, there are several demonstration projects using different drugs utilizing the infrastructure. ConcePTION's developed biobank protocols and best practice procedures to do that human collection system. Okay, if we go to the next slide. And finally, we've talked a lot about the generation of data, but also don't forget there's also a tremendous amount of work going on the dissemination of knowledge from that data. So there is a new knowledge bank being developed, which will go online. Don't try and go in there now. It's not up and ready, but we have finally chosen a name for it, which is very appropriate. MUMS, which is Mothers Using Medicine Safely. But basically, again, it's really about standardizing. I mentioned this earlier, standardizing the way that we analyze the various data sources, publications, etc., so that we can get both succinct knowledge given to the women in a clear fashion, but also then, if you want further information, to be able to get more detailed knowledge, especially for the healthcare professionals. So if we go to the next slide. Of course, the other thing we're working on is what happens at the end, because it's all very well to develop these wonderful systems, but then that needs to continue after this project has finished. So we've been looking at where things add value. It may seem very obvious to everyone, oh, we need this information, that's true, but the value is different for different people who are involved. So we're really clumped into those two main areas, which is the knowledge generation and knowledge dissemination. Because who funds this moving forward may be completely different. Industry may be very interested in developing the guidelines of how to produce better information on breast milk, how to get better information on their drugs being utilized in women. We don't want women taking any of our drugs if they shouldn't be. But then on the knowledge dissemination side, I think it's quite accepted, rightly or wrongly, that industry should not be part of that, and that should be more independent. So it's a little complicated again, but there's certainly quite a lot of groundwork started, and that's going to be accelerating through this year and next. So that brings us to the end of the presentation, I believe. I think the next slide said questions, but before we go to the questions, if you go to the next slide, if you are interested, there is another webinar coming up on the 15th of March. That was 4 weeks today. And what that's about is actually being developed by the knowledge dissemination team. It's a toolkit